Welcome to the Neuroscience Education Institute podcast. I'm Dr. Sabrina Siegel with NEI, and I have here as my guest Dr. Andrew Cutler, and we are talking about novel approaches to antidepressant treatments beyond monoamines.
Hi, Sabrina. It's a pleasure to be here. What I wanted to talk about is the fact that we know that antidepressants take a long time to work, our current antidepressants. And why is that? Antidepressants increase the monoamine neurotransmitters almost right away. So obviously the antidepressant effect must be something beyond that. And what we think is that the final common pathway for antidepressant effect may have to do with neurogenesis, with synaptogenesis, or perhaps with increasing growth factors, or perhaps decreasing neuronal oxidative death. So these processes may take time for a simple alteration of monoamines to be effectuated.
It's very interesting. What are some of the novel treatments that you can share with us? Kind of what's on the horizon?
Sure. Well, first of all, there's a number of different things that have been shown to be effective. We know, for instance, the ketamine, which is affecting the glutamate system, has been shown to have rapid antidepressant effects. And we're talking in a matter of hours or perhaps even minutes.
Wow.
And so what's going on there? Well, we think that ketamine, through its actions at both NMDA receptor but also at AMPA receptors, we think that ultimately results in increased synaptogenesis and also increase in dendritic spines, dendritic spines can pop up and pop down in a matter of minutes. So that kind of makes sense that ultimately that's the final common pathway or the ultimate biologic process that we're trying to effectuate to give an antidepressant response. And it could just be that using our traditional antidepressants by increasing monoamines like serotonin, norepinephrine, and dopamine, that may just be a very inefficient way of getting to what we're trying to get at eventually. So affecting the glutamate system is certainly one novel approach and one way of doing this. We're also learning more about the HPA axis, so we're learning about glucocorticoids and stress response system. That's not necessarily a new idea, but there are some newer drugs in development that appear to be more targeted and more, perhaps more effective than some of the older treatments that were being looked at. So that's another area. You know, the brain is loaded with hormone receptors, and I've always wondered, why don't we have more drugs, more treatments that work through hormone systems? And part of the problem is that hormone systems are ubiquitous throughout the body, and so there's a lot of collateral damage and a lot of side effects through doing this. But more and more now, as we learn more about these hormone receptors, we're able to develop more targeted treatments that target more precise hormone receptors rather than more global hormone receptors. Now, another chemical system that people are looking at is the opioid system. Opioids unfortunately have sort of a bad connotation because of the problems we have with people overdosing and dying, addiction. OxyContin, for instance, brings up a bad connotation. But the fact is, we have opioid receptors in our brain, and they're there for a reason.
Right.
We have endogenous opioids, which are the endogenous chemicals that are naturally occurring in our brain that bind to these receptors. And there is ample evidence now that for depression, this system is dysregulated. There's something wrong with this system, and there are drugs in development now that target opioid receptors, and we do have some evidence of efficacy for some of these medications. One in particular is a combination of buprenorphine and samidorphan, which is working through both mu and kappa opioid receptors.
It's very interesting. So this all seems very promising for treatment-resistant depression. Could you kind of speak to that?
Well, first of all, we know depression is a very heterogeneous illness. We know that the symptom complex and the presentation is different for different patients, and probably that is the clinical manifestation of different underlying biologic processes or different biologic subtypes of depression. So it only stands to reason that some people are going to respond to some antidepressants and not to others. The problem is that for, 50, 60 years now, our treatments have all kind of worked a similar way. They've all worked through the classic monoamine neurotransmitters, again, serotonin, norepinephrine, and dopamine. And so there are probably people who their pathology is not related to that. Their pathology may be more directly related to impaired synaptogenesis, oxidative stress and damage to nerve cells. And so these other pathways might be more targeted to their particular underlying pathology. And so these more specific treatments might be able to now help subgroups of patients that are not helped by our currently available antidepressants.
Well, I think that's all very exciting. It seems like this will help us have a much better sense of personalized treatment approach.
Well, it's really important to individualize your treatment regimen. So it's very exciting. You're absolutely right. It's very exciting to have more options to combine in unique and novel ways to try to individualize. Ultimately, it would be nice to have biomarkers, whether that's genetic or otherwise, to tell me, look, you have this kind of depression that's responsive to opioid manipulation or glutamate manipulation, or you're fine with monoamine medicines. So I think that's down the road. The brain is so complicated that the genetics are really complicated, right? So, but still, we still hold out hope that we'll be able to have these biomarkers to help us really efficiently. Other fields of medicine, such as oncology, have great genetic biomarkers, and that helps you to decide specific treatments, specific chemotherapy, for instance. We're not there yet in psychiatry, but at least if we can develop these medicines that have newer, different mechanisms of action, at least it gives us more options to try to individualize and get the best outcomes for our patients.
Absolutely. Well, it's pretty powerful stuff. Thank you so much, Dr. Cutler, and thanks for tuning in to the Neuroscience Education Institute podcast.